thank you very much for this opportunity to join your great association, Emirate Nursing Association, and the UAE chapter of AORN this morning. Let me start by saying good morning from the city of Glasgow in Montana, USA. And I want to say good afternoon, good evening to our people joining from different parts of the world. I want to say good evening to you, my good friends over there. Thank you for inviting me to speak on this very critical topic that has become much of interest to most of us that work within the healthcare system. Because we are passionate about our patients, we are passionate about their safety. And that is why the concept of timeout is so critical, especially at this point where we are actually celebrating the timeout, because June 10 is apparently the timeout celebration day. So why do we have to celebrate surgical safety timeout? Yeah, we have to celebrate surgical safety timeout because of wrong site surgery. The incidences of wrong site surgery, wrong patient surgery, wrong procedure being carried out on our patient. And that is why the issue of surgical timeout has become something that has been very critical when it comes to preoperative nursing practice. What are the expected outcome today? So my job here is just to give us an overview of what surgical timeout is. And I'm going to do a little bit of focus, more focusing on the implication of surgical timeout, especially in robotic surgery and then in our vulnerable pediatric patient. So at the end of this presentation, you should be able to identify the component of surgical safety checklist. And then, of course, we should have the knowledge on how to define surgical timeout. And of course, recognize timeout as a universal protocol, the Joint Commission Universal Protocol for Safe Surgery. Yeah, I'm going to give us one or two economic importance of timeout in surgery, but I'm not going to dwell much on that because we have other fantastic speakers who's going to be telling us about the critical need of timeout, especially from the quality and safety point of view. Okay, for this presentation, I have no conflict of interest. And then, of course, my presentation is intended to serve as a professional nursing education, just to help us to, a form of knowledge sharing to develop a preoperative nursing competency around safety in surgery. So let me start by giving us a little background about surgical timeout. Surgical timeout is one of the critical components of the World Health Organization surgical safety checklist. Yeah, shortly in my subsequent slide, I'm going to give us a brief background history on how we came about this critical tool, this critical element, which has really proved itself to provide safe surgery outcomes globally. So the timeout is a critical element that has been recognized by the Joint Commission, and it has also been recognized by the WHO Surgical Safety, Safe Surgery, Safe Lives, and then of course our professional organization AORN standards also emphasize on the critical need of preoperative nurses, our preoperative team members, to ensure that we initiate surgical timeout before incision for every patient, either patient undergoing surgery under general anesthesia or any other invasive surgical procedure, which could even be under monitor anesthesia care, or even when your patient is conscious. In fact, as a matter of fact, in the endoscopy, now, even whether you do your endoscopy under sedation, conscious sedation or not, you have to still do timeout, which is critical for what? For safe outcomes. There are a lot of studies out there which has actually shared information on how the lack of surgical timeout or the lack of appropriate standardized measures to ensure that we have safe surgery outcome has led to wrong site events, wrong surgery. It could be wrong procedure, and it could be wrong patient that has been brought in for a wrong procedure in our operating rooms. So we're going to look at some evidence-based studies shortly after that. Yeah, it is critical, and it is just striking to know that more than 70% of operating room never events are preventables. And that is why the WHO, the Joint Commission, and the other safety organizations are actually at the forefront to ensure that globally we do the right thing to protect our patient and ensure that they receive no harm when they come through us. So what are the components of surgical safety checklist? Just to start with, the WHO's surgical safety checklist has the three major components: the sign-in, the timeout, and the sign-out. However, there are two critical pillars of a patient safety that has been added to what we do in the operating room. The first one is breathing, preoperative breathing, and the post-operative debriefing. They are both also critical, to ensuring that we provide optimal patient care for patients coming to our operating room, and as well to ensure that we have safe surgery outcomes without creating or causing any harm to our patient. So I don't know how many of you that do breathing before you start your operating activities each day in your facilities. This might be different from one facility to the other. Some might do their breathing, especially during the ordeal, where you look at all the list of cases you have in a day and ensuring that you have all the necessary materials, all the necessary equipment. And in terms of environmental preparation, you know that your operating room is safe for safe surgery outcome. In terms of personnel preparation, you know that you have the right surgeon, you have the right anesthesiology or anesthesia provider, or CRNA, depending on what the kind of anesthesia provider you have in your organization or in your operating room. You want to ensure that you have the right and a competent scrub tech, a competent operative nurse or circulating nurse, a competent surgical team members to care for your patient for that particular day. At the end, in any need for maybe implants or any special equipment for that procedure, it is important that the surgeons, during the briefing in the morning, when the whole team comes together to have a briefing, that is when you say all the concerns you have for safe surgery outcomes. And that is where you identify potential problems and you can plan to address those that can lead to what? Mishaps during surgery. So because of that, I just want to quickly emphasize the fact that breathing, preoperative breathing is very critical in addition to our sign-in, our timeout, and sign-out, the WHO component of a surgical safety checklist. And as well, debriefing is very critical. And that is where you talk about the surgery that you've done. Everybody confirm that the right surgery has been done. And if there is any additional procedure that have been added according to your consent, informed consent given by the patient, you have to talk about it. That is where the anesthesiologist or the anesthesia provider, during the debriefing, they tell everybody, the team members, any plan for postoperative pain management, and if anybody have any concern for post-op management, you are to speak up. So that's just a little background. I'm just going to run through some of the talking to us today. Yeah, historically, it is important that we know that the Institute of Medicine landmarks to hear its human reports revealed that up to 98,000 Americans, were dying every year from preventable medical errors. That was in 1999, just to give us a little background on how we came about the timeout and why we are celebrating timeout as one of the critical tools, in the patient safety and equality initiative today. Then by 2003, the Joint Commission responded to this amazing alarm of people dying from wrong surgery, wrong site surgery, wrong patient surgery, which are preventable medical errors. So the Joint Commission responded by mandating the universal protocols. The universal protocol is to make sure that making a formal timeout a non-negotiable standard for every accredited facilities. So, and with that, that was able to checkmate some facilities, hospitals, or ambulatory surgical centers where surgery is being carried out. Not only surgery, any invasive procedure. Not only invasive procedure, any manipulative procedure that required the patient to come through the operating room or ambulatory surgical centers. So it is now a non-negotiable responsibility for every hospital to ensure that they formalize timeout, and we're going to get to that definition. So the timeout is that intentional, deliberate, full stop pause that every team member has to come to a halt before you make an incision on your patient. And this is critical because it is imperative for every team member to come to a halt, to stop whatever they are doing and to observe the surgical timeout. And it is not because of anybody, it is because of our patient. Our patient is at the center of care, and these patients are vulnerable under anesthesia. They are vulnerable, and they have given us their trust because they cannot protect themselves. They cannot speak for themselves. And because of that, they are giving us their trust through consent, through an informed consent. And they believe that we as surgical team members, especially the preoperative nurses, will be their advocate when they cannot speak for themselves. So it is an intentional, it is a deliberate full stop pause that every surgical team members need to observe when you are to commence the surgical incision. Just before you commence the surgical incision, it doesn't take more than 90 seconds to do surgical timeout. But unfortunately, the best surgical team in the world still struggle with timeout. Even here in this country where I am, sometimes the best surgical team, they struggle to do surgical timeout. Not that they don't do it, but to do it effectively. And we are going to see some of the implication of that shortly. So in 2004, the WHO, decided to come up with Safe Surgery, Save Lives. And that was why we have the surgical safety checklist, which has now been used globally, worldwide. And then, of course, we are accountable to making sure that we do surgical timeout before every surgical incision, because depending on where you are, maybe in UAE, maybe you are being accredited by COSASA or by SafeCare or by the Joint Commission, but here in the US, when we talk about Center for Medicare and Medicaid, they make sure that they look out for facility that doesn't do timeout. And because of that, they might lose their accreditation. So I think because of that, it is imperative that we as an individual, we want to protect our license. Then as a facility, we want to make sure that they protect their own accreditation. And because of that, it is important that we do surgical timeout. So who should carry out an effective surgical timeout? Who should be responsible? Registered nurse circulator, the surgeon, anesthesia provider, scrub nurse, surgical technologists. In fact, including the what do you call them? The vendors, the surgical equipment vendors, the implant vendors, when you're in the operating room, they need to stop whenever you are initiating the surgical timeout. Everybody needs to stop. Everybody needs to look up. Everybody needs to listen. And that is where you talk about the patient. We look at everything. I know Mr. Said is going to give us more qualities about the element of surgical timeout in his presentation. There is something that I want to pass to us today that is very critical, because depending on your institutionalized policy on surgical timeout, because there must be a policy for every operating room, which serves as a bylaw to make sure that all surgical team members, everyone, including surgeon, we understand the surgical team members, are involved in this proclamation of surgical timeout. Everybody must be involved. It is not when you are doing, the nurse is reading out the timeout, and that's when the surgeon and the scrub tech are draping the patient. No, everybody got to stop. Everybody have to pause. The anesthesiology has to be ready to even participate. So it involves everyone's participation. But AORN guidelines for team communication does not treat timeout as a suggestion. So timeout is a core responsibility of a nurse circulator. It is a core responsibility of a preoperative nurse. However, in some facilities, from my experience as a travel nurse in the US, sometimes some surgeon may want to be the one to read out, to say the timeout. So it depends on your facilities, policies, and procedure that would determine who initiates the surgical timeout right before the surgical incision. But the most important thing is that everybody must participate in the surgical timeout. A good example, I work as a circulator and I'm to read out the timeout. I have to say it loud, like, let everybody pause for a timeout. Can everybody pause for a timeout? And with that, everybody needs to stop whatever they are doing. Everybody needs to look up. Everybody needs to listen to me. And with that, I'm going to read out the patient's name. We're going to talk about the patient identifier using your patient's name, the date of birth. And at the same time, we're going to talk about, maybe if you want to talk about gender, but most importantly, we want to talk about the surgical procedure that the patient has consented for. The surgical procedure you are going to read out in your timeout must be exactly the same statement in terms of procedural that has been written on the surgical consent form. You cannot use abbreviation when you are reading out your surgical timeout. So, and these are kind of a quality checks that we need to put into consideration when we are doing that. So it is imperative looking at these guidelines from AORN. AORN guidelines for team communication is available right there for all of us as preoperative nurses to utilize. I won't have to go through all this, but you can use this slide because of my time. So surgical timeout, which is that intentional full stop pause, must be what? Must be initiated every single time for every patient. It's not that we've done surgical timeout in the morning, during the ordeal, we've done debriefing, we know all the cases we have for the day. No, individualized surgical timeout. Individualized surgical timeout, where you identify your patient by two independent identifiers. Like I've said earlier, the full name, not an abbreviation, the date of birth. You must say this loud. And during surgical timeout, there is no noise, there is no music. If there is music, you have to pause. And that is why we say that it is a deliberate and intentional surgical team responsibility to ensure that you pause before you do that incision and initiate something that will protect our patient. And it fosters, interdisciplinary communication. Surgical timeout is when we come together at the same time to evaluate and validate our individual responsibilities to our patient. So it is critical. It is very critical. So you need to talk about the procedural confirmation. You need to talk about the laterality. You want to make sure that the right procedural site is what you are doing, and that is what is on the consent, and that is what it is marked, and it is visible for everybody. And when you finish draping, prepping and draping, it is still visible before you make the incision. And that is talking about the surgical site marking out. So we want to talk about patient positioning. We have the right, maybe operating table devices for appropriate positioning to ensure that patient is safe throughout the surgery in terms of manipulation of the surgical positioning. Of course, equipment and implant are very critical. It is not when you made the incision that you want to talk about you do not have the right size of the maybe of the total knee implants. We do not have the right size of the total hip implants or the right size of whatever implant that you need for that procedure. And that is where you have to check everything. It is a critical moment in the patient's life. It is a critical moment in our lives as healthcare professionals, preoperative team members, to ensure that we do the best for our patient. And our responsibility is to care for our patient, to give them that optimal patient care, and to ensure that we have safe surgery outcomes, not only just once, but at all times. So team introduction is very important. It is also critical to talk about antibiotic prophylaxis. This is critical. I must say this. Recently in my facility, there was effectively surgical timeout. One of the importance of surgical timeout that I want you to take home today is that it fosters effective communication among the surgical team members. And you have to communicate with your anesthesia provider. Do we have the appropriate antibiotics, prophylaxis for this patient? Do we have the right one? We check the allergies, we check everything. You make sure that it's not contradicting to what the allergy band on the patient is showing. So after the timeout, the surgeon is going to say the procedure he or she is going to do. It's going to say some potential, maybe there's be some potential complications. So we can plan ahead of time if there could be potential complication. That's if there could be. And that is why before the patient comes to the operating room, the surgeon will make sure that the surgeon has done the risks and goals or risks and benefits of the surgery, explain the risks and benefits of the surgery to the patient. And then, of course, anesthesia provider need to explain the risk and benefits of the type of anesthesia, general, spinal, whatever kind of anesthesia they want to administer on the patient. They have to explain to the patient so that the patient understand that this every activities in the OR might come with some risk, but we have good plans to make sure that we mitigate these risks before it happens. So there's going to be an open floor for concern. Before the surgeon make incision, the surgeon needs to ask everybody, scrub tech, do you have any concern? Circulator, do you have any concern? Anesthesia, do you have any concern? My assistant, do you have any concern? Then the surgeon can now go ahead and make the decision. This is important because it allows everybody to speak up. So surgical timeout allows you to speak up during surgery. And if you want to reduce the incidence of wrong sites, wrong procedure or wrong patient surgery, it is critical that you initiate, as a matter of fact, quality improvement. It should be a quality improvement project for any facility that is not doing this at this time, because it is important that we begin to initiate this. All right. What are the evidence-based cases around the world? There are many evidence bases around the world. You can look them up. They are all there in the internet, in the literature. In the US, between 2007 and 2009 in Rhode Island, there was a surgical mishap when the neurosurgeons at that hospital operated on wrong cerebral hemisphere of a patient. You might be thinking that, oh, the brain is just a single organ. So the brain has different hemispheres, the right and left hemisphere. So in the case, it's just like you walking on the eye. So it is important that everybody understand the fact that whatever hemisphere that you are working on the patient's brain must be identified and must be said aloud during the timeout that we are working on this side of the brain. It is critical. Another incident in the US between 2008 and 2019, there have been some incidents of limb amputation, wrong leg amputation, and then wrong intraocular lens errors. And the literature speaks for itself. In Australia too, there was, an incident of, almost losing the LD kidney, when the patient was to have maybe left nephrectomy, total nephrectomy, and the patient, is being prepared for the right one. So that is what surgical timeout try to mitigate. The problems of wrong site surgery, the problem of wrong patient surgery, the problem of the possible and preventable error of what? Of a wrong procedure. And then, of course, in Saudi Arabia, there was another incident recorded in 2014 of a patient coming for occulopexy. Occulopexy is like you trying to, what occulopexy is a therapeutic and a therapeutic procedure to make sure that the testes of the patient is working properly. Let me just use that word. Why orchiectomy or orchinectomy is like you are taking out the whole. Ectomy means bringing out, cutting completely. The patient came for orchiopexy, and the patient eventually, the surgeon carried out, orchidectomy on the patient, and that patient lost the testes. And there are many incidences like that, and that was why I tried to give you a comparative summary table of some of the incidences that has been happening across the world. I made mention earlier that the best surgical team in the world with available resources, competent team members, still struggle with surgical timeout. And that is why the incidence of wrong site, wrong procedure, or wrong patient surgery is still increasing. We want to ask why. And I know that other speakers will talk about some of this reason as we go on. So if you look at this picture of this table, it talks about the rate is increasing, even with the available surgical timeout. Then why are we having this problem? We are going to look at that shortly. So why timeout is critical as one of the critical components of the universal protocol. It is imperative that we do our pre-procedure verification. I will continue to reiterate on this, I've said it many times. Pre-procedure verification is the first step according to the universal protocol. You must ensure that patient identity is checked, against the two separate identifiers based on the protocol. And then, of course, the procedure you are going to carry out is the same as the procedure that the patient has consented for. And if your surgery requires laterality, that is having like maybe two organs in the body, it is important that the surgeon mark it legibly for everybody to be able to see it. And that surgical site marking must correspond to what is in the consent form. And it is important to have all the implants and the imaging. That's another issue. There have been an incident somewhere around in one of the countries of this world where a wrong procedure was carried out on a patient because the surgical team do not display the appropriate X-ray imaging or the CT scan or the MRI. And this, for example, I think it was on a young child that had a lumbar procedure, and then maybe the patient was to have maybe laminectomy or lumbar procedure, maybe TLIF, L3 to L5, and the surgeon do not have the X-ray imaging to show where the problem is, to validate rather where the problem is before starting the procedure. And the surgeon decided to work on maybe L1 to L2 instead of maybe L2 to L4. And this is why one of the reasons why having an imaging in the operating room is critical for all the procedure that requires imaging. Likewise, the surgical site marking we cannot overemphasize on the importance of surgical site marking. So it is imperative. Then the final, which is the surgical timeout, is that moment where everybody needs to stop. I'm talking about it again. It's not that I'm repeating myself, but I want to make sure that we reintegrate what we are talking about here. Why we are here today is to ensure that we have no reason to skip timeouts during surgery. We have no reason to skip surgical timeouts before an incision. It is a must for all surgical members to ensure that we initiate surgical timeout during procedure. What are the economic importance of timeout implementation? We have the economic importance in terms of the positive and the negative side of a surgical timeout. If you do not do the surgical timeout, of course, there will be issues. There will be problems. The patient may have wrong site surgery. The patient may have problem with preventable errors that we ought to have mitigated from the first place. But however, in terms of the direct cost of wrong sites and the wrong patient and wrong procedure surgery, there are a lot of money that goes into that. You can lose your accreditation as a facility, and then of course the surgical team members may be faced with a lawsuit. And that's talking about the malpractice and litigation cost. And accreditation is another issue which may come as a consequence of not initiating surgical timeout which perhaps would definitely lead to wrong sites, wrong procedure in our operating room. Return on investment of timeout compliance. In a situation whereby you have a surgical team members who are currently on investigation, of course, their license is going to be withdrawn. And for that reason, those surgical team members will not operate during the course of the lawsuit. And it takes the facility to look for money to bring in another team members. So there's going to be what? A lot of money that goes into it in terms of return on investment. So there's going to be a loss of return on investment, workforce and operational costs, and of course, the global economic impact on the patient, individual patient, family, and the country. So this is just a positive economic case talking about prevention is cheap. It is better that we prevent surgical wrong side surgery or surgical mishaps when we do our timeout effectively and appropriately at the right time, every single time for every patient. These are possible things that could impact our patient, that could impact us as surgical team members, that could also impact our facility. So timeout is more than a checklist. It is more than just a checklist. It is not just a checklist like, okay, we just have to take it. It is a deliberate and a quality safety initiative that we have to undergo, that we have to initiate for every patient. So it is important that we look at that from the perspective of psychological effect on the team members, psychological effect on the patient. If a patient should lose the wrong team, the wrong limb, that's going to stay with that patient for the rest of for the rest of such patient's life. If a patient should lose a wrong limb, a wrong leg because of with wrong side surgery, that's a major issue in that patient's life. So we need to look at that as patient advocates to ensure that we learn from other organizations, other maybe sectors. Aviation is one of them. You know, they always make sure that they do checklist, make sure everything is checked before they decided to fly any aircraft. Likewise, in the OR, we want to make sure that we do not only observe the checklist, but we do it intentionally with the mindset that we are advocating for safe surgery outcomes. All right. So briefly, I want to talk about surgical timeout when it comes to robotic surgery. This is a little bit different. The timeout you do in robotic surgery is the same timeout, the same method, but just with an extra caution. You need to go extra mile to put in other things in perspective when it comes to robotic surgery. I love robotic assisted surgery. And why is this important? So the timeout here should be what? Should be done rigorously. It should be done meticulously before you dock your robot arms. And because the robot arms have different kinds of arms, the technology involved, the different software involved, and because of that concept of robotic assisted surgery, it predisposes patients, quote and unquote, to possible harms, especially when things do not go right with software or with technology. Because technology can always fail at any time. And because of this, we want to make sure that before you dock your robot arms, onto your patient. Now, and when I got to let me use my experience. When I get to the room every morning, because as a nurse circulator, I see my operating room as my house, and other people are coming to visit me. And it is my responsibility to make sure that my house is in good order for my guests to come. The surgeon is my guest. The anesthesiologist is my guest. The scrub tech is going to be my guest. The student is going to be my guest. So because of that, I make sure that everything in my robot room is functioning. I have the right equipment. We've done the basic troubleshooting to make sure that the robot is in good and functioning status. So you want to make sure that you want to try to manipulate the patient positioning before patient comes to the operating room to make sure that you can go through the lumbar, you can do lithotomy, you can do everything as planned for that particular procedure for that moment. You want to make sure you try that. You make sure the bed is paired with the vision card, the bed is paired with the robot, all the systems are working together. They all sync, working together effectively to ensure that our patient do not have any harm during the procedure. So, and there are also specific technology things that we need to check. In terms of instrumentation, you want to make sure that you check your instrumentation. You want to make sure that your instrument is not expiring, like the robotic instrument is not expiring that day. You want to look at the shelf life of that robotic instrument before you dock it on the patient, because you want to minimize coming out and going, with docking, except when it is necessary. So it is imperative that we make sure that all your equipment that you need for optimum patient care during surgery and to ensure safe surgery outcomes are all working well, are all in good order to ensure that we have a fabulous day in the operating room. And with that, you can smile to your patient after surgery. In the recovery, you can smile to your patient. The whole team is happy. And that is how you can go back home and sleep with your eyes closed. All right? So there are different cases of incident of robotic mishaps during surgery. And that is why for robotic surgery, we need extra measure. We need to be more meticulous when it comes to surgical timeout. Aside from identifying your patient with two independent identifiers, aside from talking about the procedure you want to do, aside from you confirming the procedure with the consent, aside from surgeon verbalizing that truly this is what my patient consented for, aside from the anesthesiologist saying that, hey guys, for this patient, I'm not giving this type of antibiotics because the patient is allergic to these families of antibiotics. Therefore, this particular antibiotic is safe and the surgeon is happy with it. Aside from the scrub text saying that, oh, I have 0.25% bupivacaine plain or with epi, 1 in 200,000 epinephrine on the feed as doctor has ordered for that patient, that is safe for that patient. Aside from the anesthesiologist and the scrub tech and the whole surgical team members agreeing that this is the maximum dose for this kind of local infiltration. Those are safety measures. Those are key performance indicators those are key safety indicators for safe surgery outcomes. You want to look at the medication you want to give. Is this medication appropriate to this patient's age, weight? You want to make sure that. So aside from doing all those normal things that we do for everyday timeout, when it comes to robotic surgery, you have to go extra mile to make sure that you look at the technology. You do specific technology check. It is important. I'm going to say that again. It is critical that you check everything before you bring patient to the room. And everything must be checked just right before the incision. And that's why when you are doing your timeout, in addition to all other things that we've talked about today, we need to talk about the equipment, that the robot is good. We have the right instrument. We have the shelf life of the robotic instrument are still good. And then, of course, we have everything that we need in the operating room. And, of course, we have perhaps the reps in the room. And if you don't have the reps in the room, you have the phone number of the reps. But now with D5 robots, the surgeon and the team can do a virtual communication. They can have a virtual communication with anybody around the world while the procedure is still ongoing. So it is critical that we look at that. Now let's talk about our vulnerable patient, the most vulnerable patient in the hospital when it comes to surgery, the pediatrics. I've had opportunities of working across all ages, patient ages, from neonate to adults. But when it comes to pediatric patients, they are the most vulnerable patient that we have, and we have to encounter in our operating room activities on a daily basis. Because these patients do not have that knowledge, the full knowledge of what they are about to go through. Because surgery for every patient is like a journey. And it is important when you are preparing for a journey. For an adult, you prepare your mind psychologically, you prepare yourself physically, but children do not have that luxury of opportunity to be able to prepare themselves. And that is why surgical safety timeout has really saved many lives of our patients from wrong side surgery, or from wrong, procedure. Because when we do or proclaim or initiate surgical safety timeout, we are helping these vulnerable patients that are very, very critical for safe surgery outcomes. So who we identify these particular patients, they do not have the knowledge to express themselves mostly. And that is why we are there to help them. They cannot identify truly, especially depending on their age. The neonate or the less than 3 years old patient may not necessarily be able to identify what kidney is, the right kidney is, depending on the age of the patient. So because of that, we need to put extra effort as patient advocates to ensure that we be their mother, we be their father, during that procedure. And we help them through, including their family, we help them through the journey, the surgical journey, throughout our facility. From pre-op to intra-op to post-op, it is the preoperative team members' responsibility, especially the preoperative nurses, to be the patient advocate and to speak for them when they cannot speak. So because they are voiceless. So many dosing errors have actually occurred in the past because of their critical size in terms of their weight. And that is why it is important that we match the patient weight with the appropriate dosage of local anesthesia, and appropriate, dosage of a local anesthetic agent, and appropriate dosage of any medications that we want to give to this patient. And likewise, we have to get appropriate equipment. Those are the things we look for. Those are the things we check when we're doing the timeout. As a circulating nurse, you want to ask your scrub tech, do we have appropriate sizes for this particular laparoscopic orchidopexy for this patient of 5 years old? So with that, the scrub tech will validate that, okay, according to the surgeon preference, and during the timeout, the surgeon will say that, okay, those are the instruments that I really need to use today by my preference. Or in case there are special equipment, we want to validate that we have that special equipment in the operating room. It's not the special equipment that you'll be waiting for vendor to bring from maybe 5,000 miles away. So you have to have it right in the room before you make incision. And that is why surgical timeout is so critical to patient safety. There are many incidences, case scenario of, wrong side surgery in Canada, even in the US, in some other countries in the UK. You can look them up. But my responsibility today is not to talk about those problems in the past, but for us to be able to come together to know how important surgical timeout is, to ensuring that we provide that optimal, perioperative nursing care. I'm using the word perioperative now because before, during, and after is everybody's responsibility to ensure that we mitigate any preventable errors that may occur. So we know that sign out is being carried out in the intraoperative phase of patient care. But however, looking at the Joint Commission Universal Protocol, it is imperative that we make sure that everything is checked from pre-op phase to intra-op phase. And we have our debriefing to ensure that a necessary plan is made for safe surgery outcome post-operatively. Okay. So what happens when we skip surgical timeout? A lot of problems will happen. It's not a guess. If you skip surgical timeout, be ready to face the lawsuit because things will go wrong. It's not a cause. If you skip surgical timeout, to tell you how critical this element is, when it comes to patient safety, then you are ready to create a lot of problems for yourself. You are ready to create a lot of problems for your facility. You are ready to create a lot of problems for your, unfortunately for your patient. I'm sorry, I'm not trying to be harsh, but that's the truth. It is imperative that we proclaim surgical timeout. It must be part of your policy and procedure for your operating room. It should be part of your quality improvement initiative for your facility, that for every patient, at every single time, at every moment before surgical incision is made, surgical time is initiated. Surgical timeout is what? Initiated. And everybody is happy that we are about to do the right thing for the right patient on the right part of the body for our patient. So if you skip surgical timeout, you're going to harm your patient. If you skip surgical timeout, there is legal and regulatory fallout waiting for you. Because wrong side surgery is the Joint Commission never event, and the mandatory reporting of it is critical. Mandatory investigation is critical. There is no exception. And that's why if it happens, you have to document, what you call an incident report. It's unfortunate that you have to do a lot of root cause analysis. It may take a longer weeks. It affects your operating room efficiency. And that is why we should not skip what? Surgical timeout, aside from the patient. So as I'm rounding up, there are gaps. What are the gaps? What are the major causes why people skip surgical timeout? Why do the best team in the world still struggle to do surgical timeout? People still struggle to do it because the surgeon is on your neck, because you have like 15 cases, on your list for your room, because you don't want to speak up, because surgeon is the head of the team. You don't want to speak up. No, surgical timeout has given us the opportunity for everybody to speak up. When you see something, say something. Are we together? When you see something, say something. So surgical safety timeout has really helped to foster that effective communication among the surgical team members. So, and then when it comes to familiarity, it's going through the emotion. This surgeon is my friend, is my best surgeon. And the surgeon comes to the room, you are doing the surgical timeout, the surgeon is draping, and you cannot say, stop, surgeon. You need to stop, doctor, because we need to pause for this timeout. So you should be able to do that. And the leadership of operating room facilities in the world should be able to encourage nurses to speak up to any wrong practice within the intraoperative patient care. Then documentation gap is another issue that has been major challenges for surgical timeout. So people do surgical timeout and you can go later, maybe after your patient have left the OR, that is when you start your documentation. When you initiate a surgical safety timeout, you must document it in real time, that it is done right now before you do your timeout, and I'm documenting it right now before the incision is made on the patient. So documentation gap has been around people delaying the time they document the surgical safety timeout. So timeout, when it is initiated in the operating room, when everybody is happy, you must document it immediately when it is done. Otherwise, you're going to miss, there's going to be some gaps. For example, here in my experience as a traveler in the US, different facilities have different methods when they do their surgical timeout. Some will do timeout, they will include the fire risk. Some will do the timeout, they will not talk about allergies. And that is why I said that the best team in the world still struggle with surgical safety timeout. So this topic is critical at this moment, and I'm really passionate and I'm very grateful for your organization for inviting us to talk about this today, because this is what we need to be talking about this month, throughout next month, throughout this year, not just only June 10 when we're celebrating the surgical timeout. Noise and distraction is one of those challenges that may impair effective surgical timeout in the operating room. As I'm rounding up, the following are the strategies that you can employ. You can probably employ these surgical strategies in terms of compliance, because it takes less than 90 seconds for you to do surgical timeout. But because you have so many cases and a lot of pressure on you, surgical timeout might look like 5 minutes in front of you, like you have taken the whole day. Whereas it takes less than 90 seconds. If everybody is willing to come together to do it the right way at the right time, it won't take more than 90 seconds for us to initiate surgical timeout. But when you have a lot of pressure on you, the nurses feel the pressure and it looks like it's going to take you like 5 minutes, then you want to skip it. So don't skip surgical timeout. Do it every time, every single time for every patient. So there must be one standard surgical timeout for each operating room. Not that you have a separate surgical timeout for OR1. There's another one in OR2 because they do neurosurgery there. There's another one over there. No. And then, of course, the leadership should be able to understand it. So as I conclude, when patient gets to sleep in the operating room, they give us everything about their lives. They entrust everything to us. And when you do surgical timeout, you are protecting that trust that they've given to you. The only way you can protect your patient trust in surgery before an incision is made is when you do what? When you initiate surgical timeout. Not initiating it only. Every pause saves lives. You need to stop, you need to verify, and before you proceed. Always initiate it, always document it, and always advocate for your patient. Thank you so much for.
We are so happy to have you here. I'm welcoming you all for with the Emirates Nursing Association and the Compass Health Consultancy. Actually, after Dr. Johansson presentation about the timeout, he already spoke about the timeout from operational perspective, preparation, understanding, and how you are actually dealing with the situation. And what is he highlighted a lot about the documentation and the knowledge and verbalizing, understanding, and all of that. So thank you so much, Doctor, for your for your thoughts and for your presentation. And for me, I want to speak about timeout as a critical indicator for safety and better patient outcome in the operation room from a quality point of view, quality perspective. And we want to focus on the patient verification and the team communication inside the theater itself, and the wrong side prevention, how we are able to identify it, and how we do measuring for the OR reliability through electronic system, through verification, through ideal protocols that we have using dashboards. And the message from that is like cognitive pulse, shared situational awareness, and stop the line safety culture. So I welcome you all in this presentation, and thank you so much for attending this webinar. So before we start to do or to speak about that, I want you to consider this as actually it's something really, really important as a part from the international patient safety goals, and it can lead to life-threatening situations, and it can really, really make a big difference in people's life. So startingly, if I want to say about the core elements of the high quality timeout. When I say what is the core elements, I need to understand first what is the high quality timeout that I want to achieve. For example, if I want to start doing checking the quality timeout that I have in the OR, I need to make sure that I have, first of all, 2 identifiers for the patient. I have to make sure that I am doing a match for the wristband. I have to make sure that I have proper charting for the patient, proper consent, proper identification. I have to make sure that the full procedure with the code that I have for the patient is matching what I have in my system or my papers. I need to make sure that the patient should be laterally, should be supine, should be semivowler, should be which side, what is the visible mark that has the patient. Plus, we need to go a little bit about a clinical risk confirmation that it's actually highlighted more about what is the allergy the history that the patient have, what is his present illness, if he has any airway concern, if he has a risk of a separation, if he's vulnerable, if he's above 65, if he did multiple surgeries before, and when was the last surgery he did. And one more thing that many people that are not really concerned when we speak about the preparation of timeout and the timeout process itself, that the antibiotic prophylaxis and the anticoagulation that we are giving to the patient, when the process of antibiotic was started, when the antibiotic will finish, how I will make sure that really it's actually given like 30 minutes or 1 hour or in the beginning of the before the incision of the patient or the skin breakdown. And the estimated or the accepted blood loss that we'll have from the surgery, especially for the surgeries like, let's say, the vascular surgeries. So for me, I need to put in my consideration all these aspects from a quality point of view. My equipment, my anesthesia machine is working, my monitor is working, I have a backup machine, I have ready equipment for the airway, I have, I have a circulatory nurse, scrub nurse, I have backup nurse there, I have a surgeon assistant for the surgeon, I have like a good access. So all these core elements is concerning about what or how I can make a proper time out inside the theater. So best practice that we have one leader, one script, one shared understanding. Now, for the people who are actually working in the OR and they are actually interested in the OR, they know that maybe the timeout process will be done loudly. There will be a verbal communication between the team and the surgeon and the anesthesia through a specific dashboard or through a specific form inside the OR and proper checking for that checklist. So that will give us an idea about where we are standing inside the theater. So why this is actually very, very, very important, because it's covering a core element of high quality of timeout. So now let's go to think more abroad inside the quality of the timeout as a clinical quality indicator. How quality measures the reliability of pauses before the incision. Yani when I start to speak about the procedure or the timeout, I make a pause before the incision, everybody is silent, everybody is listening to me to what I say. So clinical indicator in that particular point defined as a measurable process showing whenever the full timeout occurred correctly, loudly, and with the whole team before incision. Now, I just want to highlight a little bit about, we will talk about it in more details in a few slides, but I wanted to talk about the using of system, the using of electronic system. In doing that, or using of a specific dashboard can give me a specific information attached with the time, so it will be much more reliable and much more objective. So once I do the timeout inside the theater, I have to click or check on that we did it exactly, for example, at 6:28 p.m. So at that moment of time, that capture data that I have will affect, first of all, my incision time, will affect my legal aspect regarding the timeout, and it will focus not only in the whether the form was signed by the patient and procedure, but it will give me an idea where I am actually confirming and what kind of way I am confirming. So how I will do that? By firstly checking the data source, the quality view, and the target, and the numerator and the denominator, and the surgeon himself need to be accepted this or approval on that before doing the procedure. Now, let's go more about the quality perspective by how to measure whenever timeout is truly working or not. Remember when we mentioned at the beginning that we are actually using dashboards, we're using system, we're using verification. Now, once you admitted the patient on the system inside the OR and you start the procedure, the system will give you automatically that the timeout need to be done now. And he will stop you from doing any documentation at that moment of time unless you do the timeout properly. So once the timeout is done and it's confirmed by the surgeon and confirmed by the circulatory and the OR team, then after that, we want to see that we are actually doing truly timeout or not. First of all, process metrics that I need to first pass compliance with full verbal timeout. Means I'm standing inside the OR, I'm giving a full loud verification for the patient. Patient participation in the site marking visibility, like I'm using a permanent marker. It needs to be site, its right leg, left leg, right lower quadrant, left lower quadrant, whatever. And second thing, that the antibiotic timing, as we mentioned in the introduction, antibiotic timing is very important and it should be given 30 minutes to 1 hour before the surgery or before the incision. Outcome metrics, wrong site or wrong procedure, near miss need to be verified. And the culture metrics, speaking up behavior across all disciplinary. If you suspected that you have a problem, if you suspected that you are unable to do this procedure for this reason, speak up before the incision time. And audit method, we have, of course, direct observation. We can use, let's say, in case that the system is available, that I'm not able to do any verification at that moment of time. So measure the pose itself, not just the paperwork after it. Right. Okay. Now, if we use like a system and the system is reflecting for us a reliable data, as we mentioned in the introduction, how actually it will look like if I have a proper dashboard and electronic system for the timeout monitoring. Remember, we are actually speaking about the quality perspective, not only the operational perspective. So if I have, in this example, if I can see in this example in front of you, now the dashboard example is giving you that the electronic system convert timeout performance, okay, into real-time quality data. Now, the leadership can see completion rate, on-time performance, read back documentation, and open discrepancies. If you can see this slide, like let's say, for example, I'm sitting in my office as a chief nursing officer, and I want to check exactly what I have, what was the timeout exactly today, when was the procedure was done, when it was finished. I just go to my electronic dashboard and I start to check all this. Now, that's the responsibility of the nursing leadership or the nursing admin or the OR admin to make sure that this process is actually done perfectly to reach up to 100% compliance. Now, the workflow should be prompt the timeout before incision. And I'm highlighting that before incision because if you did it after incision, that we are not having any reliable data. And Also, the dashboard updated automatically because it's connected with time that you press or that you enter the data at that moment. The organization can monitor trend, coach unit hits, and react quickly instead of waiting for delayed reports. Like if I want to see that I have, let's say, 100% compliance at that moment of time, and I have a compliance of the antibiotic, let's say 88%. The next month it was 90%. The consent was signed exactly 94%. 95% I have, let's say, the patient arrival within 15 minutes to the OR. So all these aspects, I will collect it and I will work for it in order to make sure that I am 100% compliance. Right. Okay. Now, because I have the availability of electronic system, HIS or EPIC system, or whatever is actually controlled from my side, electronic tracking for legal protection and patient safety. Now, in USA, it's very, very important, and it's very, very, aspectly very important that your documentation is actually protecting you from having any legal issues. Now, let's say that you admitted a patient to the OR and you didn't do a proper timeout. What is the perspective? What is the legal perspective for the physician himself, for the OR team, for the hospital, the hospital repetition, and what is the legal aspect from that part? So legal and regulatory values is time stamped evidence of what was confirmed and when. That's how the system will help me identify who participated in the timeout, who's the person signed electronically, create an audit trail for investigation and review. Now, from patient perspective, prevent any missed checklist, prevent any missed mistakes. Any mismatch will be tagged immediately. And we are actually supports rapid escalation when the team find there was a discrepancy. Now, from quality governance values, especially for the hospitals that they have shared governance program, turn every case into measurable data. These data will be reflected in your dashboard. It can be used later on for improvement purposes, okay? It can increase the highest care given to the patient, increase the patient satisfaction, increase the patient or better patient experience, and maintain or make sure that I have a patient-centered care as part from the nursing department. Help leaders proven reliability during accreditation and review. If you have accreditation for CBAHI, GCIA, Magnet, whatever you have, it's like confirmation for your work. Now, a digital timeout creates a very traceability, accountability, and safer escalation. Electronic trial supports safety and legal, responsibility, as we mentioned. Right. In order to make it much more easier and much more understanding, let's take this case study. The case study is like timeout prevented a wrong side operation. Now, before the timeout, I have a patient is booked for a left knee procedure, but the schedule entry and the room board shows that it's right knee. The patient is prepped and draped. The surgical team is ready to do the procedure quickly because they are in a hurry because they have a lot of patients and they have a full schedule. During the timeout, the nurse reads the consent, site mark, and imagining aloud. The mismatch is noticed immediately and the team stops the line. Now, during and after the timeout, the surgeon anesthesia team and the nurse recheck the consent and marking. The order is corrected before incision. The correct side is confirmed verbally, documented electronically, and the case is processed safely. A wrong site operation, reoperation, and avoidable legal exposure are prevented. So here is that what we have before and what we have during and what we have after. Why it's actually matter? Because timeout is a high value clinical barrier. It catches an error when it can still be corrected, protecting the patient, the team, and the organization. And as the doctor mentioned, he giving you like a huge number of data of mismatch that's happening in yearly based in USA, which is very, very, very big numbers that we are actually trying to decrease year after year. Now, if we want to, at the end of this lecture, what we want to take as a key take ways. First of all, treat the timeout as a patient safety intervention, not a routine task. And you need to do it every single time as something not routinely. It's an interactive intervention, part from the procedure that you want to do, part from your checklist, part from your international patient safety goals that we are actually applying everywhere, and specifically the OR. Standardization improve reliability and reduce variation in practice. And once I have a standard procedure, that's mean I will make sure always that I'm doing the same workflow and pathway. And we don't want to forget effective communication in the foundation of safe surgical site. When I have a proper, loud communication inside the theater, okay, I'm highlighting and I'm making sure that everybody's understanding. I'm speaking English, I'm speaking one language, and everybody can confirm my timeout language. Every team member shares a responsibility of speaking up, as we mentioned, for verifying any critical information. And also, as a nursing leadership or as a leadership generally, regular audits and feedback helps sustain long-term improvement. And while I'm doing that every single day, I'm actually making a strong safety culture for my staff, for my patients, for my surgeon, and for my organization. So a strong safety culture transforms a brief pause into wonderful harm prevention strategy. And success of timeout is actually measured by meaningful engagement, not by the speed. So even if I have a long day, a long procedure, I have a lot of procedures daily, I need to make sure that I'm doing this every single time without any speeding up. Every pause before the procedure is an opportunity to prevent an error. Just put it in your mind and make sure always pause, always pause, always pause, always verify, always communicate, and always protect. Now, a specific timeout prevent harm today. Like if you do the timeout today, you are preventing the harm of tomorrow. You are strengthening the culture of patient safety in your hospital. Thank you so much for listening and for joining our webinar today. Last message, always pause, always verify, always communicate, always protect. Thank you so much. Thank you.
Assalamu alaikum. Thank you so much, Mariam, for the introduction. On behalf of the NAOR Society and the UAE ORN chapter board team, I would like to thank our guest speakers for their valuable contribution and for supporting our societies in advancing safety and excellence in surgical care. I would like also to extend my gratitude to everyone who joined us today for this webinar and took the time to engage and learn with us. Finally, I would like to take this opportunity to invite all the perioperative nurses across the UAE to join our society so together we can continue to enhance collaboration, share knowledge, and advance perioperative practices for safer surgical outcome. Today in my presentation, we'll review perioperative essential competencies and common challenges in leading an effective surgical timeout process, and explore evidence-based strategies, education initiatives, and capacity building approach that enhance compliance, teamwork, and patient safety in the operating room. We all know that operating room is one of the highest risk environment in healthcare, where a single misstep can have irreversible consequences. Within this environment, the perioperative nurse play a critical role in safeguarding the patient journey. The surgical timeout is not a formality. It's the final structured safety barrier before incision. It ensures that the entire team pause, align, and verify critical patient and procedural information. When perioperative nurses are well prepared, confident, and knowledgeable, they become the key drivers of safety culture. Their role goes beyond task execution. They actively shape communications, vigilance, and accountability in the OR. After all, safety in OR is not a task. It's a clinical culture led by perioperative nurses. Having explored the critical role of the perioperative nurses in surgical safety, we now turn to one of their most essential responsibilities in the OR, ensuring safety during the surgical timeout process. The perioperative nurse play a critical coordinating role during the timeout process. And this is, as you know, the final opportunity to confirm that every detail is correct before the surgical incision begins. Beyond checking documentation, the nurse ensures that the entire team is engaged and actively participating. The OR nurse also acts as the communication bridge, ensuring that everyone is involved and ensuring that any discrepancy, no matter how small, is identified and resolved immediately. This moment is essential because once the incision is made, many errors become irreversible. Time out, again, is the last defense before harm occurs. A major challenge in perioperative nursing education is the lack of consistent and standardizing training across healthcare system. Many nurses enter the OR with different level of training and experience in perioperative practices, especially in our region where we have a big diversity workforce. Not all nurses are up to date with the latest guidelines, best practices, and new technologies, like the AI tools that we use in healthcare. The limited use of simulation-based learning reduced opportunity to practice high-risk scenarios, such as timeout communication failures. Also, the top-down OR structures may make nurses feel less comfortable speaking up or raising safety concern, even when patient safety is at risk. Heavy workloads limit time for continuous learning and skills development. And there is also limited investment in perioperative education and unclear career pathway, which can affect professional growth and retention. As a result, there is a gap, a big gap, between what nurses learn in theory and what they apply in real practices. So strategies that can support building a strong perioperative nurses workforce begin with investing in continuous education and professional development for the entire OR team, as this forms the foundation for a safe and effective surgical care. To support this foundation, standardization, specifically in our education, is critical to ensure that we are on the same page, ensuring consistency in core competency and enabling new staff to integrate safely and effectively into the operating room environment. Once this baseline is established, education must be enhanced through alignment with the global best practices such AORN guidelines and hospital policies. And this will ensure that the best care is done with the delivering of evidence-based practices with high quality of care. In addition, we need simulation-based training that play a critical role by allowing nurses to practice real-life OR scenarios in controlled and safe environment, thereby enhancing clinical judgment, teamwork, and response to complex situations. And to further advance clinical excellence, professional certification such CNOR is highly valuable as it validates competencies and builds knowledge and confidence in perioperative decision-making. Alongside this, it's essential that our nurses develop a strong understanding of a quality improvement and risk management principle, since these are directly linked to patient safety and surgical outcome. Finally, we need to engage our nurses in our KPIs, tracking such as timeout, compliance, and infection prevention indicator. Reinforcing accountability encourages ownership and actively involve them in improving clinical performance and outcome. After all, we need to develop perioperative nurses to be a clinical safety leader, but not a task performer. In the MEA region, perioperative nurses have access to clear pathway for advancing their practices and career development. Through the Compass Health Consultancy, the exclusive provider of AORN certification training program in the region. These certified programs foster perioperative excellence at every stage, from Periop 101 for entry-level OR nurses to CNOR certification for advanced competency and leadership. Also, they support excellence in perioperative safety and quality of care and the development of competencies in quality improvement, risk management, and OR performance optimization. To further support professional development, a special 30% discount is offered today for all perioperative nursing attending this webinar. When perioperative nurses are well-trained, competent, and empowered, the impact on surgical safety is significant. Compliance with the timeout improve, turning the process into a meaningful patient safety activity rather than a routine procedure. Skilled nurses enhance communication with the OR team, ensuring that potential errors are identified early and correct before harm occurs. This leads to a stronger situational awareness among all team members and significantly reduce the risk of preventable surgical events such as wrong side surgery. Beyond technical outcome, skilled perioperative nurses continue to be a strong and provide a strong culture of patient safety where speaking up is encouraged and valued. This ultimately improves patient outcome and enhance overall surgical quality performance. At the end, skilled nurse transform timeout into a life-saving safety intervention. In conclusion, the perioperative nurse is not just a participant in the surgical process. They are a key leader in ensuring patient safety. The timeout should never be viewed as a routine checklist, but rather as a critical leadership moment where the entire surgical team aligned for patient safety. Investing in education, certification such as Periop 101, CNOR, and more, adherence to AORN standards, and engagement in quality and risk management all contribute to improving perioperative nursing practice. When healthcare organizations invest in developing their OR team, they directly improve patient outcome, reduce error, and enhance surgical quality. After all, a strong perioperative nursing workforce creates a culture where safety, accountability, and teamwork are embedded in every surgical procedure. And we need always to remember that patient safety in surgery begin with the competent and empowered operative nurses like you. Thank you so much for your attention. And Mariam, the floor is yours.
The first question for Dr. Johnson. Do we have to confirm with the surgeon the position of the patient on timeout? Dr. Johnson?
Oh, thank you, Miriam. That's a fantastic question. I'll say yes. Yes.
Yes.
We need to confirm the patient positioning. Surgery starts with positioning. Safe surgery starts with patient positioning. Aside from identify the right patient, the right surgery, the right laterality, it is imperative that you confirm the right positioning during timeout. If you know something that can lead to mishap, that's why we said that the surgical timeout has given us the opportunity for you to say something when you see something. So nothing you say in the OR sounds stupid. So if it requires you talking about reconfirming or affirming the right patient positioning during the timeout, you need to do that. However, the positioning ought to have been discussed during the briefing before patient gets to the room. So that is very critical. That has to be said on the the surgeon preference, the preference card. You need to confirm verbally, even when you have it on the surgeon preference card. You need to confirm with the surgeon. And then, of course, before you send for patient every day, we do see our surgeons around. If they are not available, we have their phone numbers. Like, doc, I know this procedure. Your preference is, okay, supine with hand table. Would you like to use hand table or do you want to do it on an handboard? So that verbal confirmation is protecting you, is protecting your license as a nurse. Then when the patient gets to the operating table, whatever that you think, if you're in doubt of anything, you need to say it. And the whole team needs to what? To verify, to deliberate before an incision is made. If it requires you moving the patient, even though intubated, to back to the trolley, and for you to get the right thing done for your patient, for you to have safe surgery outcomes, it's worth it. However, like I've said, it is imperative that you identify everything that would be that's going to contribute to safe surgery outcomes during the briefing. There must be briefing before you do your signing. There must be briefing before you get the patient from pre-op. And it is during that briefing that is when the whole surgical team comes together to say, this particular patient, okay, surgeon, I want to do this procedure. And during this procedure, I will want the patient in supine position, and I'm going to make the incision, maybe midline incision. I'm going to ask for this type of suture. I'm not going to use Vicryl this time. I will prefer the V-lock, which is different from my preference card. So it's just that most of the facility we miss to do the briefing before we send for the patient. So if it requires you to say it during the timeout, go for it. Everybody's going to appreciate it. So that's my answer. Yeah.
There is another question for you, Dr. Johnson. What about laparoscopic procedure converted to laparotomy? Timeout needed or not? The same team proceeding the laparotomy.
Thank you very much for that question. So, for example, here in the US, there have been some issues with surgical consent. And I think most of the facilities now, the surgeon now take the consent, informed consent from the patient. For example, most of the consent we have here for laparoscopic procedure used to have an additional word statement added to it. For example, for all our laparoscopic cases, we do have laparoscopic appendectomy in most of the facilities, laparoscopic appendectomy, and any other indicated procedures. And any other indicated procedure. Sometimes people will say laparoscopic appendectomy with possible open. appendectomy. So with that, if you have your consent and you have read out the consent during your very first time out, and you are converting to open surgery, there is no need for you to do another time out. You get it now? But your consent do not give that option that you are converting to open. In fact, if you convert to open, it might lead to some medical litigation because your patient did not consent for open surgery. Are you with me now? So that is why
Yes.
the consent is very informed consent that is very clear, is very, very critical to save surgery outcomes. So for every consent that we have that I've seen in most of the places I've worked here, is that we are doing laparoscopic appendectomy with possible open. So in that case, the surgeon is going to explain to the patient before patients move to the operating room as part of the risk and benefit that we are doing laparoscopic, we are taking out your appendix laparoscopically, but we may probably convert to open if need be. With that, the patient understood that, and the patient is giving the whole trust to you, the surgical team, through that consent. So the consent must give an option, an alternative, like an umbrella information that if it is not this way, any other indicated procedure that will make us to take good care of you, we are going to do it. Are you happy to do that? Are you happy to go ahead with the surgery? Yes or no? And once the patient is able to verbalize that, then you are happy. So as a perioperative nurse, when you go to the pre-op area, as a circulating nurse or the operating room nurse, when you go to the pre-op area or to the floor to get your patient, one of the things you need to look for is how the consent has been written out. If the consent is written laparoscopic appendectomy, you may want to check with your surgeon. Like, are you sure this is all we are going to do? Guaranteed 100%? If not, the surgeon might be called to add like any other indicated procedure to that consent. And the patient must be aware of that, and the patient must give us the go ahead to do that. So I think the issue of consent is something that we should also talk about in one of your programs, in one of your webinars, so that we'll be able to really deal with the issue of informed surgical consent, because that is a great question from that person, and I think it may impair an effective surgical timeout during the procedure. But if your consent says laparoscopic appendectomy with possible open or laparoscopic appendectomy with any indicated procedure, then you don't need to do another sign out to convert to open, because patient has consented for everything and you all understand what it means with any other indicated procedure. But if something is not clear and there is any concern, I will always say, speak up. Everybody's going to reason along with you, and you have to be happy. Everybody on the surgical team needs to be happy before we start surgery on our patient. And with that, we can guarantee that we are providing optimum patient care that is safe for all our patients. Thank you.
Thank you, Dr. Johnson, for your valuable answers. Saad, I will come back to you later. Caroline, there is a question for you. Should preoperative nurses be equipped with the quality management skills to enhance patient safety and improve surgical outcomes in the operating room?
Thank you, Mariam. And I would say yes, and yes, and yes. We expect from the perioperative nurses to be skilled not only with the clinical, but with the quality management, risk management skills, because this will help to improve patients' outcome. And these skills can help to reduce error, improve compliance, and enhance safety protocols. So as a perioperative nurses, look at yourself and said, okay, what I need to improve my skills. Do I need clinical? Do I need risk? Do I need quality? What is my career development? Where I want to be? And start building your skills to achieve your goal of excellence.
Thank you, Caroline. Saad, What is the most effective strategy to ensure the surgical timeout KPI is consistently achieved and sustained?
Yeah, thank you, Mariam. Thank you for Dr. Johnson and Dr. and Miss Caroline for their also input. Actually, in short, like I can say, the most effective strategy is active engagement and objective auditing. As we mentioned in the lecture, we mentioned that we want to do an objective assessment, numbers, reliability, system, dashboard. So active engagement, loud communication. So stop all activities, be silent, look to each other, the surgeon, the nurse, the anesthesia, verbally confirm the part of the surgery in loud voice. Okay, do not rely on self reports, do not rely on somebody tell you something. No, everybody should hear each other. And as per the international statistics from WHO, 47% from the communication happened inside the OR was not clear, and this is a huge percentage. So silent, active engagement, objective auditing, and real-time feedback through dashboard. Thank you.
Thank you, Saad, for your answer.
Okay.
There is.
I think I saw your question here. Somebody's talking about if healthcare institution truly conducting independent, unbiased real-time observations of timeout compliance, or are we relying on self-reported data that may not reflect actual practice? Yeah, I would say, if I may speak to that question, I would say yes. Yeah, my facility to do that. And as a matter of fact, we do have a designated individual. Sometimes it could be a nurse, it could be a scrub tech that will be the one to go through every operating room to ensure that he or she observe if timeout is effectively initiated. And she's kind of a police of the room for that day. And we document that and we collect the data every month. And we do have a report that is being passed to leadership as regards to that. And not only that, occasionally, I think quarterly, effectively quarterly, affirmatively quarterly, the operating room governance, starting from all the directors, including infection prevention practitioners, every individual from leadership, from CSSD leadership, that is Central Sterile Supply Department, to infection control, to biomed, they all come to the OR to also observe surgical timeout in my facility because they try to make sure that not only the junior staff is doing it or we are documenting it, we are relying on effective data, but however, they are trying to show us by leadership to make sure that they are part of this and they want to make sure that this is being done. And with that, it gives all the preoperative nurses that confidence to speak up because now they have people, they have their own leadership in the room with them when they are doing it. So there is no fear of this is a locum surgeon. This surgeon is not, he's just coming, he's a new surgeon and he wants the timeout to be done this way, aside, different from what the policy of the facility has stipulated. So because of that, they comes to the room and they give you that kind of morale that you should do your timeout and they want to observe if anyone is too big to stop whatever they are doing. And through that, everybody is taking it seriously. That has been done for several years and they are not ready to stop now, even though we are doing it appropriately. But the PIP for timeout is being done every day. So, like, you have people like coroners. When you're having like a morning assignment, we have someone that is supposed to do that. The person needs to do at least, maybe not for every case is possibly, but at least they do for the first case or second case as they move around the rooms. So everybody's like at alert that we have a police moving around the court today and everybody must do it. Do we need to have somebody to police us to do the right thing? I would say no. The right thing must be done by the right people. Who are the right people? The surgical team members. Because we want to do the best for our patient. This should be an operating room culture, a culture of safety. And that is why we cannot overemphasize on the importance of surgical timeout, in a patient safety. Thank you.
Okay, Dr. Johnson, there is one more question for you. In the emergency surgery and code purple, no time to do timeout. What we can do?
The urgency, like I said, one of the challenges that we've been having, why people skip timeout is the urgency. There is no urgency. And the Joint Commission has already said that surgical timeout is non-negotiable. When you have a patient coming through the emergency, and of course the role of the emergency team members, depending on the kind of case. Here in the US, there are a lot of re-trauma cases, multiple gunshot injury. Even with that, we still do timeout. Why? Because the patient will be stabilized at least to some extent before getting to the OR. Why is it that the best surgical teams still struggle sometimes if in case of emergency? My own answer will be that because there are other things that ought to have been done. Maybe it's supposed to have like an emergency laparotomy set ready. You are just using your time. You are spending so much time on other things that you ought to have done before emergency arrives. So emergency preparedness is very key. When you are adequately prepared for any trauma emergency, there is no way you will not have less than 2 minutes to do timeout. So I want to say that it is non-negotiable. Your patient is either intubated or being bagged from ER coming to the OR, even when it requires that you need to make decision in the emergency and rush the patient to the OR. There is always that gap, that moment that will be available for everyone to be able to quickly pause while you keep your eyes on the monitor, but you have to stop whatever you're doing and actively participate. That this patient came with a traumatic leg injury. This patient is going to be amputated. This patient also have gunshot injury. So then we have multiple surgery on patient. There is always a potential error that is going to happen when you have multiple surgery. And that is why surgical timeout is to take care and mitigate those preventable errors that will occur from multiple surgery. And especially in trauma cases, in emergency cases, that 2 minutes, less than 90 seconds, is critical. Is critical to saving your patient's life. Is critical to making sure that you do not walk on the wrong side or on the wrong part of the patient. It is critical to ensuring that you advocate for the patient that is very vulnerable. So it is not negotiable for me. And then, of course, many facilities, like there was a facility I worked with before coming to my new place here. There was a study, a lot of simulation. Every minute counts, every second counts in emergency. When you have everything ready for emergency, you're going to have that time. That time will be there for you to do timeout. So I would say that irrespective of how critical that emergency is, in as much that your patient is intubated, in as much that your patient the anesthesia is happy. And then, of course, you cannot go ahead with any surgery if your anesthesia providers are not happy. So that moment when the patient is asleep, before the incision, that is what we call timeout. Before the incision, that is what we call timeout. That moment must be provided. That minute must be created. And everybody must actively participate in the proclamation of surgical timeout. Thank you.
Thank you, Dr. Johnson. I am sorry, but we cannot take all the questions now. We will do our best to return to them after the session. We have reached the end of our webinar. Our sincere gratitude to our speaker for sharing their expertise, insights, and valuable experience. It was a pleasure to have you with us today. Thank you to everyone who attended and participated. We also want to extend our appreciation to the Compass Health Consultancy for sponsoring this webinar and supporting the advancement of preoperative nursing education in UAE. We hope our preoperative nurses found the session valuable and engaging. We look forward to welcoming you to our future webinars and workshops. Join today the NAOR Society and UAE-ORN chapter, and together we advance preoperative nursing excellence in UAE. Save the date for second NAOR Society and UAE-ORN chapter symposium on 15 November 2026. Stay tuned for more information. Have a great evening.
Thank you. Thank you, everyone. Have a good evening.
Thank you so much.
Thank you, everyone. Thank you for having me.
Thank you, Dr. Johnson. Thank you.
Thank you.
Thank you, Syed. It's nice to see you. Thank you so much.
Thank you. Bye-bye.
Thank you. Thank you, everyone.